Good morning, ladies and gentlemen. We welcome you all for yet another Sunday weekly webinar series organized by the Society for Health Research and Innovation. Society for Health Research and Innovation is a national CPD provider which has been running since 2021, and this is the 217th lecture of this series. Before moving on to the lecture, let me walk you through some of the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for the CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. We thank you for the strict adherence of the CPD regulations and your kind compliance. We maintain these to improve the standards of the CPD programs conducted by the Society for Health Research and Innovation. There will be a question time at the end of each webinar. If you have any questions, you can type it in the chat function. Please change your chat settings to all panelists and attendees so your questions can be answered. If you have any specific questions, you can email us on office330@gmail.com. Today's topic is eczema and eczematous skin conditions. The lecturer for today is Dr. Ranthilaka R. Ranawaka. She's a consultant dermatologist at the Lady Ridgeway Hospital for Children, Colombo. With 25 research publications in index journals and an author of 27 book chapters internationally, she's an expert in the field. We warmly welcome you to conduct this webinar. Over to you, madam.
Right. Good morning. Thank you for the introduction. So my topic is atopic eczema and eczematous skin disorders. So we'll go to first questions. Now this is a family physician. This patient, you can see. So the family physician has treated for eczema. But this is recurring again. Why? Because this is an eczematous rash. So treatment is like eczema. But the problem is here, it is rubber contact dermatitis. So they have to advise on avoidance of the allergen. That is very important. So there are eczema-like disorders which are not exactly eczema. So this one, you can see, is a 7-year-old child with an eczematous rash on the posterior thigh. So I tell you, do not prescribe topical steroids on this child. So I tell you, this is an eczematous rash, but I tell you, no, don't apply steroids on this child. Why? Because you can see these punched out ulcers. So this is eczematous rash. Treatment for eczema is topical steroid, but this child has punched out ulcers on top of eczema. So this is eczema herpeticum. So that's HSV infection. So we have to treat with acyclovir first. So after a few weeks of settling acyclovir only, we treat for the eczema. So question 3 is, this is a 72-year-old woman. There's an eczematous rash around the mouth. So again, her GP had treated with topical steroids, but no improvement and getting worse. Why? So there's an eczematous rash. Treatment is topical steroids. But this is irritant contact dermatitis to saliva. So this woman is edentulous. So therefore, there's drooping saliva. So we have to educate the patient and they have to avoid the causative factors. So this is irritant contact dermatitis. So again, you can see this rash in a 3-month-old baby. Again, treated correctly with mild topical steroid. This is improving, but recurring again. So they have taken to another doctor, treated with Candacort, that is steroid plus antifungal, improving, but recurring. So what is the diagnosis? Why is it recurring? So this is nappy rash, that is irritant contact dermatitis to urine. So we have to educate the parents to avoid the irritant or the allergen. That is very important. So this child has atopic eczema. So it is diagnosed. So it's correctly treated with antihistamines, condace, topical steroids, and antibiotics. It is well improved, but it is not cured. So mother is not happy. The lesion is not cured. Why? So diagnosis is atopic eczema, that is correct. Treatment is correct, but we have to educate them. This has a natural history. So atopic dermatitis will resolve with time. It takes about 10 to 12 years, right? So until then, we have to treat them symptomatically. So we have to educate the parents and the patients, right? So eczema is the commonest skin disease in our clinical practice. That is inflammation of the skin. We call it dermatitis. So there are many etiologies and there's variable intensity of itching and soreness. Dryness, erythema, excoriation, exudation. So there are many features in eczema. So dermatitis and eczema. Dermatitis and eczema are generally regarded as synonyms. Dermatitis is inflammation of the skin. So all eczema is dermatitis. All eczema has inflammation of the skin. So it is dermatitis. But all dermatitis is not eczema. So inflammation of the skin, all are not eczema. Right? So some authors still use the term dermatitis to include all types of cutaneous inflammation. So this is a non-specific terminology, right? So classification of eczematous dermatosis, we can come to. There are exogenous and endogenous, right? So exogenous in key strategy for exogenous eczema is to remove the cause. Endogenous eczema, that is mostly atopic eczema, more often requires pharmacological intervention. So we need drug treatment for endogenous eczema, and it takes time to resolve. So we have to educate them. Exogenous eczema are usually allergens, allergic or irritant contact dermatitis, right? So it is there, we have to remove the cause. So depend on the etiology, whether it is allergic or irritant or clinical presentation, there's classification. It is acute eczema, chronic eczema, lichenified eczema, pompholics we call, discoid eczema. So depend on the clinical presentation also, different names are used. Depend on the etiology, there's allergic or irritant. There's exogenous and endogenous. Endogenous eczema is mostly atopic eczema. So endogenous eczema, first is atopic, but there are other conditions: seborrhoeic eczema, steatotic eczema, discoid eczema, eyelid eczema, pityriasis alba, hand eczema, venous eczema, metabolic eczema or eczema associated with systemic disease, and eczematous drug eruptions. So endogenous eczema more often requires pharmacological intervention. Exogenous eczemas are irritant contact dermatitis, allergic contact dermatitis, photoallergic contact dermatitis, eczematous polymorphic light eruption. So key strategy for exogenous eczema is to remove the cause. Endogenous eczemas. So we know endogenous eczemas. So out of endogenous eczemas, this is the most common, atopic eczema. Especially in children, this is the most common endogenous eczema. Atopic eczema is extremely common and very complex. in the majority of cases, it starts during infancy. So in our clinic, more than 50% are eczemas. So out of them, many are atopic eczema, especially in infancy. So atopic eczema starts during infancy, usually less than 2 years of age. So most of them coexist with other atopic conditions like allergic rhinitis, hay fever, bronchial asthma. We don't have hay fever in this country because we don't have hay. So otherwise, allergic rhinitis, bronchial asthma are associations in the individual or other family members. So if you ask whether they have a family history, they will give. So not only eczema, but some of them have bronchial asthma, some of them have allergic rhinitis, right? So it's individual or family members. Atopic eczema patients have a filaggrin mutation, therefore associated with other clinical features with filaggrin mutation, like they have ichthyosis vulgaris, keratosis pilaris, hyperlinear palms, right? So most atopic subjects have reduced defense against staph and secondary infection. Therefore, their secondary infection with staph is very common in them. So you can see this infant is itching, and you can see the infant is very fair compared to the mother, and the father also was close to mother's color. So child is very fair. Actually, we don't know the reason, but we have observed this a lot. With severe atopic children, they are very fair. But when their atopic skin problem settles, they get their normal skin color. So pattern of the rash in atopic children varies with age. So this in infantile phase, the lesion starts on the cheeks and other areas of the face. When they start crawling, exposed surfaces, extensor surfaces get affected. Then in childhood and adult phase, the sites most characteristically involved are the elbow and the knee flexures. So flexures of the elbows and knees. And in adult also the same, childhood and adult, same. So management of atopic eczema, right? So management of atopic eczema takes, it takes 10 to 12 years. I told you, in atopic children, you have to educate the parents that it takes time to settle. So they have to keep on treating the patient. So we can't do miracles, like within few months, we can't cure atopic children. So it takes 10 to 12 years to get complete or near complete remission. Therefore, management is symptomatic and it should be conservative. And whatever the drugs we use should not cause any long-term sequelae, right? So therefore, you should not start on oral steroids on these atopic children, right? So we have to educate the parent. That is very important. So sometimes we give systemic therapy, but only in severe recalcitrant itching and for a short period. So if you find an atopic child, even it is mild, you should refer to a dermatologist, because then only we decide when to start oral treatment. So oral corticosteroids, only short course. So sometimes we give azathioprine, cyclosporin, methotrexate, even mycophenolate mofetil. So, but for a short period, because that is to relieve their severe itching and the severe symptoms. Because it takes about 10 to 12 years to get complete or near complete remission. So frequent emollients to keep skin moisture is very important. So they have to apply these moisturizers very frequently, right? Especially when the children are under care of grandparents or a carer. So they don't bother to apply moisturizers very frequently. So they want these drugs, oral steroids. So if you start oral steroids once, what these carers do, they give oral steroids from without medical advice, over the counter. So if the carer is a mother, then she won't do that. But if the carer is a grandparent or somebody else, relative, they usually give oral steroids without medical advice, because that's very easy for them to manage atopic eczema that way, rather than applying moisturizers. So this is acute eczema. So their symptoms is, one is pruritus. So you give antihistamines. So there's oozing. Therefore, we give Condis wash. So make sure that Condis, we should make it pink color, not dark purple color. So dark purple is very concentrated. So it should be very diluted Condis. So it should be pink color. So if you think there's bacterial infection, secondary bacterial infection, we give antibiotics. Usually it is staph. So you have to give anti-staph cover. So then in acute eczemas, we give topical steroids, which are creams, not ointments, creams we have to use in acute eczema. And we give, if it is very severe, we can give short course of steroids, sometimes 3 days steroids, that's all. Maximum 3 to 5 days. So advised to avoid exacerbating factors like foods or detergents. Right? Foods means, I advise only 3 foods. That is balamalu, salmon, and vinegar. Vinakiri dapu, acharu, or something like that. Vinegar, balamalu, and salmon. Don't restrict all the foods, right? So if they have already found a food which exacerbate their problem, then they can avoid, otherwise don't. So this is chronic lichenified eczema. So you can see the appearance. It is not like acute eczema. There's a thick plaque. There can be hyperpigmentation. This is post-inflammatory hyperpigmentation. And it is also itching. Itching is the main problem in eczema. So we give antipruritics. When we use topical corticosteroids, usually it is ointments, because ointments stays longer. And for these lichenified lesions, it takes more time to absorb. So it's better to give ointments. And sometimes give salicylic acid, because it helps peeling of the surface, and it helps absorption of steroids and moisturizer. So this is Pomfolix. Again, it's a type of eczema. So there are some papules which are very itchy on hands and feet. And so in atopic children, they complain of these papules on hands and feet. So you have to exclude scabies, because scabies is more common in atopic children. But excluding scabies, you can diagnose as Pomfolix and treat. So itchy, subepidermal, small blisters. Hands and feet should be soaked 3 or 4 times a day in Condis. Large bullae aspirated using a sterile syringe. Topical steroids. Usually we use potent steroids and ointments. Discoid eczema. So discoid eczema, discoid or disc-like or nummular, circular, but that is only the appearance of the lesion. disc-like or pneumonia. So it can be acute or chronic. So disc-like, circular lesions, discoid or pneumolar, name given for the shape. It can be chronic or acute. So the main differential diagnosis here is tinea infection, because tinea also is a circular rash. So you have to differentiate from tinea. Sometimes it's difficult to differentiate, even for us. When it is partially treated tinea, we can't see the active inflammatory edge. Or even if you apply steroids on tinea, we can't see the edge. So even so, sometimes we can't differentiate. So if you have a doubt whether this is tinea or eczema, first treat for tinea. Then review in 2 to 3 weeks and see the improvement. Because tinea is an infection, it gets worse with steroid application. So again, discoid eczema treatment, antipruritics, topical corticosteroids, depend on the acute or chronic, you decide. Acute, you use cream. Chronic, you use ointments. Antibiotics, if there's infection, and a lot of moisturizers after acute stage is settled. So management of eczema. Management of eczema is very easy. For any eczemas, this is the treatment. Antipruritics, you decide whether to give sedatives or non-sedatives. So depend on the age, depend on the conditions, depend on the itchiness, you decide. Sedatives or whether to give non-sedatives. Non-sedatives mainly during morning, sedatives during the night. But that also you have to decide. If the child is doing O-levels or A-levels, don't give sedatives. So acute oozing eczema. Wash with diluted Condes. If it is oozing, you have to give diluted Condes. You can't apply steroids on oozing eczema because it gets worse. Right? You have to settle the oozing first with Condes. Wash with Condes, pat dry, then apply creams. Topical steroids, you decide whether it is mild, moderate, or potent. So that depends on the site of the lesion and the age of the lesion. I'll describe it later. Penetration of topical corticosteroids can be significantly increased by occlusion. We call it steroid under occlusion, right? So sometimes we advise them to, like if they have feet eczema, apply steroids and wear socks, cotton socks. So that is under occlusion. Or they can cover with polythene, that's little cumbersome, but this is wearing socks is very easy, right? So antibiotics you can give, so you decide whether to give oral or topical. Aqueous cream as soap, because all these eczema children or eczema patients have dry skin. So it's better to avoid soap because soap causes more dryness. So aqueous cream as soap. Bland moisturizers. Bland means without any other additions. You give moisturizers. So moisturizers also you decide whether to give less oily ones or more oily ones. Depend on the severity of the dryness. And identify the aggravating factors. Like whether there are irritants, whether there are foods which aggravate them. Identify complicating factors like infections or allergies to medications. Even topical medications, they can be allergic, making eczema worse. So that's management of eczema. So there are different types of eczemas. This is called steatotic eczema. That is, the problem is, this is a 75-year-old man presented with this itchy rash on bilateral legs. So when you look at that, you can see the skin is very dry skin. and this is very common in old age. And diuretics. If they are on diuretics, it's a contributory factor in elderly people. Or this can be a presentation of mixed edema and can also due to zinc deficiency. So management is avoid soaps. So you give soap substitute, aqueous cream, and avoid detergents and cleansers. So you give soap substitutes, either emulsifying ointment or aqueous cream. So they have to apply a lot of moisturizers. Weak topical corticosteroids. If there's eczema only, we give topical steroids, but otherwise the management is a lot of moisturizers. So in initial stage, you can give topical steroids, but later on, they have to apply a lot of moisturizers. So the problem here is very dry skin, common in old age. Management is a lot of moisturizers. Pityriasis alba. So this is a 9-year-old boy with this hypopigmented, asymptomatic. It's not itchy. It's a hypopigmented patch. So you can see there's no well demarcation and it merges with the normal skin. And you can see it's very dry skin. It's often a manifestation of atopic dermatitis. But it is not confined to atopic individuals. Predominantly in children, lasts for a year or more. So again, only moisturizers. If itching or inflammation, you can give mild topical steroid, but the reassurance, educate the parents, and lot of moisturizers. So it will cure within few months. Recurrent feet and focal palmar or plantar peeling, right? This is very common. You may have seen a lot of children comes with this problem. These are asymptomatic, but there's palmar and plantar feet peeling is there, right? So there's no irritation, vesicles not seen, relatively asymptomatic. So a lot of moisturizers and reassurance. Hand eczema. So if they come with hand eczema, you have to always look for a causative factor. Example, cement contact dermatitis. Sometimes detergents in housewives or cleaners, the problem is detergents. Paint, wood polish, and sometimes gum. So you have to talk to them and see what is their occupation, what are their frequent habits. So you have to find out what they are doing with their hands frequently, causing this problem and aggravating this problem. They may be atopic people, but this is not atopic eczema. This is hand eczema. So you have to find the causative factors and aggravating factors. So again, because now you see these are very severe. This second one, right side one, is acute eczema. The other one, left side one, is chronic one. But both you have to give potent topical steroids because palms and soles, epidermis is very thick. So it takes a long time to absorb steroids. So we usually give ointments, but if it is acute, you have to give creams first, then later on ointments. So a lot of moisturizers again. So under occlusion, it enhances absorption. So you can ask them to wear either cotton gloves or cover their hands with polythene or keep for about 2 hours. Feet eczema. Again, you may have come across these patients. Again, you have to, so they may be atopic children, atopic people, but don't consider that it is normal in atopic children or atopic people, right? So we have to try to identify the causative and aggravating factors. Sometimes they are shoes, slippers, right? can even occur in atopic. So this is common in atopic people. So again, we give potent topical steroids with lot of moisturizers and usually under occlusion. So usually I ask them to wear socks. During daytime, they have to wear at least 2 hours. During night, they can wear the socks throughout the night. After applying creams, topical steroid plus moisturizers they apply, then wear a sock. Fingertip eczema. You can see these three people, this person has eczematous rash on 3 fingers only, 3 fingers. So you have to find why he is getting problem only in 3 fingers, right? If it is only one hand, you have to ask different questions. Left hand. That person may be maybe here right hand. So he hold the knife with the right hand and hold the onion or the garlic with left hand. So they can get fingertip eczema only on the left. If they get bilateral, 3 fingers, then you have to ask their routine activities which involves these 3 fingers. In our country, the commonest is plucking flowers, Vatusuddha flowers, right? Especially Buddhist people, if they are old or middle age, they every day, morning and evening, they pluck Vatusuddha flowers. With that flowers sap, they get irritant or allergic contact dermatitis. So when you see fingertip eczema, you have to ask their occupation, habits. It may be either irritant or allergic. Irritant, housewife handling detergents. Allergic, so people who use polish. So this is, we don't have tulip, but in Western countries, tulip bulbs, people who pluck flowers like the same thing, right? So it's a dominant hand now. You have to think of polish or gum. So they apply some during their occupation, they apply various things with their hands. So if it is dominant hand, it could be either polish or gum. Non-dominant hand, onion or garlic. So bilateral in Sri Lanka is commonly due to allergy to Vatusuddha flower. So you have to talk to them and get their occupations and cultural habits. So you treat the same way. Antihistamine, topical steroid, plus or minus antibiotics. But unless they avoid their irritant or allergen, this will persist. Again, this is very common. This is also fingertip eczema. You may have seen, especially in young children, teenagers, they come with this fingertip eczema. So they are again allergic to either pen, pencil, chalk, plastic, something they touch with their 5 fingers. Even this computer keyboard, plastic, they may be allergic. Shoes, socks, cement, paint, right? So again, mild topical steroids, lot of moisturizers and education, right? Eyelid eczema. So this eczema around the eye is common feature in atopic dermatitis, and it can occur with seborrheic dermatitis, or you have either, if those two are negative, then you have to think whether they are using any eyeliners, even nail varnish. With nail varnish, when they touch their eyes, they can get this dermatitis. Fragrance, rubber. If they are wearing spectacles, they may be allergic to these spectacles, ophthalmic medicaments or nickel in spectacle frames, or even eye drops, right? So you have to find it. Management, you have to remove the cause. Mild topical steroids, but lot of moisturizer. So be careful when you apply steroids around the eye, because it can absorb. So you should not prescribe them very frequently because they can end up with glaucoma. So venous eczema or gravitational eczema. You may have seen this is very common in middle-aged or elderly people, especially when they are obese. This is stasis eczema or varicose eczema. They're most often associated with varicose veins. Sometimes apparent, but sometimes varicose veins are not apparent. So this is, we have seen only in middle-aged and elderly people, right? So management is, so we can treat easily eczema. Now, you know how to treat eczema now. Whether it's acute or chronic, you manage. But the main problem here is varicose veins. So underlying venous hypertension should be controlled, right? If they are obese, lose weight. And well-fitted support stockings. So you have to ask them to apply creams and they have to use support stockings. So sometimes they take, because of this wound, I didn't apply this stocking. No, they have to apply the stocking. Otherwise, this eczema would not cure, right? So, or firm bandages can be helpful if worn regularly, but bandages are usually not very helpful because that depends on how they apply the bandage, right? So it's subjective, therefore it's better to prescribe these stockings, but stockings are expensive. The legs should be elevated as effective as possible when they are resting or sleeping. They have to keep their legs elevated. And mild topical steroids, because eczema is not the primary problem here. Primary problem is venous hypertension or obesity. So you have to tackle those two first, right? So usually we don't apply potent topical steroids because it can cause thinning of the skin. And if they have varicose veins, these veins can easily bleed when the skin is thin, because the side effect of steroid is skin atrophy. So you should not prescribe potent steroids on these people. If you apply, if you prescribe, that should be for a short period. Otherwise, you will get more problems with these venous type of eczema, which are very difficult to control unless we control their venous hypertension. So you may need surgical opinion even to control, or vascular surgeon's opinion to control their venous hypertension. So exogenous eczema. So we talked about endogenous eczemas. So now we come to exogenous eczemas. Exogenous eczemas are either allergic contact dermatitis, irritant contact dermatitis, photoallergic contact dermatitis, or eczematous polymorphic light eruption. So main key strategy to exogenous eczema is to remove the causative factor. So here, what is the problem? Now they have this eczematous rash around the hairline, involved in the tip of the pinna. And this one also has eczematous rash, now mildly resolved with depigmentation. What's the problem there? This is hair dye allergy. So you treat like eczema. So this is acute eczema. You treat like acute eczema. But you have to identify the causative factor, advise them. So you should advise them to avoid PPD containing hair dyes. So usually the allergen is PPD, paraphenylene diamine. This is what gives black color. So they should avoid PPD. PPD-free hair dye they have to use. One is this Dream Brown. They have eco hair color, but they have to apply every 5 days, it seems. So this one, you can see again eczematous rash. right? So you have to fully expose them and see this pattern. Can you see? So this you can see eczematous rash. So this woman is allergic to this bra, underwear. You can see the marking very clearly. She has had this problem for a long time because whoever the doctor seen this woman had not exposed properly and had not identified the allergen. So when you see these underwear allergies, it could be, you have to fully examine, fully exposed and examine. So it could be allergy to synthetic material or dye, even fabric dye. Like if they wear always black color, they may be allergic to this black color, fabric color. So advise them to wear white cotton underwear. Sometimes they are allergic to elastic, right? So you have to, with the pattern of the dermatitis, you have to identify, talk to them and identify what the allergen is. So in Western countries, usually they do patch testing if you suspect allergic contact dermatitis. But in our country, we don't do because we don't have all the patch test series because they have different shoe series, fabric dye series, hair dye series, different ones. One patch test kit is around 3 lakhs. So it's not worth buying for our country to identify the allergen, but looking at them, examining fully exposed and talking to them, you can identify most of the allergens. So advise them to avoid them, and in this case, to wear white cotton underwear, right? So this one again, you can see. This right-hand side, you can easily say this is due to rubber slipper. These straps, this type of straps we have in rubber slippers. So this one on left hand, you can see this depigmentation or dermatitis had been on the dorsum of the feet. So usually that is due to shoe which has contact in this area. So you can talk to them and find out what type of foot where they have, right? So this one, again, a middle-aged woman, and this eczematous rash on both dorsum of hands, extending up to forearms. So what's the problem? Ask them, talk to them. So this woman extract cow milk daily. So this is cow milk allergy. So they have to, you can treat eczema with steroids, lot of moisturizers, you know how to treat now. But avoidance of this milking cow is very important. So actually they say that they can't milk cow. Milking cow is not possible. Wearing gloves, it seems, because the cow doesn't allow that sensation. So here, again, 2 children. They have this eczematous rash on posterior thigh. The left-hand side, you can see it's half circle. But the right-hand side, so this is common dermatitis. So this is half circle. Depend on the child size. So this is a smaller child. So full common shape is imprinted on the back. So looking at that and talking to them, you can find out what the problem is. So this is due to common. So you treat like eczema, then the avoidance of contact. So they have to use a seat cover. So they can have it a old cloth, shape of this common. So you have to explain the parent. They can use a old bed sheet and make a cover, right? So they have to use this cover for about 3 to 6 months. After cure, after settling the dermatitis even, they have to continue this for 3 to 6 months. Then they can stop, because we don't see this dermatitis in adults. It's only in children. Not only, but mostly in children. So this one again. So this is umbilicus. Below the umbilicus, there's eczematous rash with depigmentation. So what's the problem? So he is using a belt with nickel. So he is allergic to nickel. So nickel allergy. You have to talk to them and find. Right? So management of allergic contact dermatitis. Any allergic contact dermatitis, management is the same. So patch test is performed to identify the allergen. So otherwise we treat as eczema, acute, chronic, depend on the oozing or lignified. You know how to treat now. Antipruritics, topical steroids, you decide. Antibiotics, if there's infection, moisturizers. The most important is to identify the allergen and avoid the allergen. So we don't have to go for very expensive tests like patch testing. We can manage looking at the imprint and talk to patients. So this one, this is eczematous rash around the mouth. This is lip-lick dermatitis. That is, the primary problem here is dryness of lips. Because of dryness, they stick out tongue on the lips to get away with the dry lips. Licking, lip licking. So the saliva get contact with the normal skin also. Saliva is an irritant when it contact with normal skin. So irritation due to frequent exposure to saliva. So irritant contact dermatitis to saliva. So they have the first problem is dryness of lips, lip licking. Lip licking make worsening of dry lips. So it is a vicious circle. So we have to break this vicious circle. Dry lips, lip licking. So we have to treat the dry lips. You can apply mild steroid for about 3 days. That is enough. But the main problem is dry lips. You educate them. You give a lip balm which contain Vaseline. There are Vaseline lip balms are there. So they have to apply lip balms very frequently. Like they have to keep their lip balm with them always. When they feel dryness, without applying saliva, without licking the lip, they have to apply this lip balm. So usually when it is with time, it becomes a habit. So they have to get rid of this habit of lip licking. Mild steroid, moisturizers. The most important is to stop this habit. So you have to educate. So and give lip balms with Vaseline. So this lip-lick dermatitis can present with hyperpigmented rash. This is hyperpigmented rash. This is eczematous rash. We saw this old lady. This is not lip licking. This is due to now they have no teeth, edentulous. Therefore, there's drooping of saliva. That's the problem. So it's difficult to avoid that, because when they don't have teeth, drooping of saliva is normal. So this is hypopigmented, so they can present like this. Now this one, you can see there are some odd irritant lesions, odd eczematous lesions, but they are bizarre shape. Different shapes are there. And the history is, it had appeared overnight. Yesterday night, I was okay. But when I woke up, I felt some irritation. By midday, they noticed these lesions. Right? So these lesions appeared overnight. This happens every year, same period of time. Sometimes people come like that. Because on examination, we see bizarre multiple lesions on localized areas. This is due to this we call blister beetle dermatitis. That is, during the night, insect crawl on our skin. Then spontaneously what happens, we try to remove the insect. Then this insect can eject defensive secretions which are irritant and cause blistering, or they can get crushed onto the skin and eject these defensive secretions. So this is a irritant contact dermatitis. Differential diagnosis is phytophotodermatitis. Phyto is plant, photo is sunlight dermatitis. So there are some plant contact dermatitis. This is most likely the lower one is most likely a plant contact dermatitis, right? Phytophotodermatitis. So removal of the toxin by immediate washing with soap and water. Affected patient should be managed as irritant contact dermatitis. So symptomatic treatment, antihistamines, topical antibiotics if needed, and mild topical steroids and education. Right? Educate them. So these ones. Now you see this hypopigmented patch. And if it goes on, it can become eczematous. Again, hypopigmented patches. If we don't treat, it can become eczematous. So these are photodermatitis, or we call it polymorphic light eruption. So avoid sunlight and sunscreens. Again, antihistamines and mild topical steroid for a short period. So the problem is allergic to sunlight. So either they have to avoid sunlight, or if not possible, they have to use sunscreens. For example, especially in children, if they are engaged in sports outside, don't advise them to avoid sunlight, because don't advise them to stop their sports. So you prescribe sunscreens. So side effects. So all these eczema or eczematous problems, we use topical steroids. So unless you use the correct steroid for a correct duration of time, for the correct skin problem, you get a lot of problems, right? So there are side effects of topical steroids. One is acneiform eruption, depigmentation, atrophy, striae. In infants, even topical steroid can cause cushingoid. This is steroid acne or acneiform eruption. These are, unlike normal acne, these are uniform acneiform, acne-like eruption. And without having acne on the face, they can have acne on the trunk. And when how we differentiate acne and steroid acne, these are uniform. Usually acne is in different stages. Some are erupting, some have already inflammatory, some are like that, right? Different stages are there in acne, but in this acneiform eruption, they are in one stage, steroid acne. This is depigmentation. In feet, dorsum of feet, you can see the normal color in this man, but you see this below knee, whole shin is depigmented, and some areas of post-inflammatory hyperpigmentation, but the other areas are depigmented. So depigmentation is a problem. You can see veins very easily because skin is atrophied. Steroid striae. So this is very thick striae, unlike during pregnancy. Striae are not very thick and look very aggressive, very red and aggressive. And this is steroid striae. Steroid purpura. Steroid purpura you get only in systemic steroids. You get this purpuric rash. So this is it's a very common mistake that you misdiagnose tinea infection and eczema. Sometimes you can't differentiate tinea infection and eczema. So these people are treated with topical steroids. So this is tinea infection. So when you look at carefully, you can see active inflammatory edge. You can see carefully. So this man was prescribed, you can see this, his forearm also, he has this tinea infection. So this man was prescribed with topical steroids or combination of steroids and antifungal. So this tinea has spread all over his trunk. So, but when you look at carefully, so most of the time when you treat with steroids, you can't see the active inflammatory edge. But even these people, if you look carefully, you will find, you see, there's active inflammatory edge. Same person, right? So this is tinea infection treated with topical steroids. We call it tinea incognito. So tinea can easily be mistaken for eczema, but if you have a doubt whether it is tinea or eczema, first treat for tinea for 2 to 3 weeks and get down them, see the improvement, and then you decide on steroid. But it should be a last option because now, as you all know, that we have a problem with drug-resistant tinea now. So principles of using topical steroids. Use steroids sparsely, very little. Do not use steroids if the diagnosis is doubtful. For example, if you cannot differentiate tinea and eczema. Infants can get cushingoid even with topical steroids. So there are different strengths, mild, moderate, potent. Mild steroids are hydrocortisone in children. In adults, face and flexures. So in infants, we can use 0.5% strength. Others we use 1% strength. Hydrocortisone, 2 different strengths. Betamethasone is a moderate potent topical steroid. So other than face and flexures, we use in adults. In children, palm, sole, and scalp, we can use betamethasone. Not in infants, right? Clobetasol is a potent steroid, adults only. Even in adults, palms and soles and scalp. Do not use in other areas, even in adults. So steroids, there are ointments and creams. Ointments on dry scaly areas, palms and soles. Scalp psoriasis, lichenified eczema. Creams, oozing eczema, acute eczema. So when you use steroids, you have to be very careful. I add this, there are 3 slides I add for all my lectures because we have a big problem now using these topical steroids on all the conditions, including tinea infection causing drug-resistant tinea. So moisturizers. Moisturizers are very important in eczematous conditions. So there are some are watery, some are oily, and in between. So more watery moisturizer is aqueous cream. Most oily moisturizer is Vaseline. In between is emulsifying ointment. So depend on the patient's skin condition, you use either watery one or oily one. So these are bland ones. So there are drugs with added to these bland ointments. So urea-based ones, glycerin-based, and there are various types in the market. There are moisturizers with lot of additives. But concentrate on this, whether it's a aqueous cream, emulsifying, or ointment. That is what is important in our skin problems. Don't in topical steroids. Do not ever prescribe combination of antifungal and steroids to any skin problem, because these two conditions, only indication is seborrheic dermatitis. So most of the time, general practitioners, it's rather difficult to diagnose seborrheic dermatitis. Therefore, always, if you are in doubt, refer them to a dermatologist. It's very difficult to diagnose seborrheic dermatitis to a general physician. It's very difficult. So that is the only indication we use steroid plus antifungal. So don't ever use these two combinations for any other skin problem, right? Use only antifungal creams if you suspect fungal infection, and only steroid if you suspect eczematous condition, right? Do not prescribe potent topical steroids to face, groins, and to children. Face, groins, and to children. Topical, potent, clobetasol. Do not prescribe topical or systemic steroids if you suspect infection. Skin or systemic. Infection, if you suspect, if you have differential diagnosis of infection there, do not prescribe steroids. Now see, now these are not in the market now. We stopped importing them. And see this Endem GM. It has all three: clobetasol, gentamicin, miconazole. One thing, it is a potent topical steroid, so you should not apply. I told you where to apply potent steroids. So don't prescribe these things. And it has antibiotic and antifungal. So don't. So this is do not, right? So we'll come back to questions again. Now see this one. Family physician treated for eczema, but recurring again. Why? So you know why. So this is an eczematous rash. You treat like eczema, but the problem is rubber contact dermatitis. So they have to avoid wearing rubber slippers. So that's the main advice you have to give. Then this one, child has a posterior thigh dermatitis. So I tell you, do not prescribe topical steroids because this child has these punched out ulcers. So this is HSV infection, or we call it eczema herpeticum. So these infections are very common in atopic children, right? So we have to treat the infection first, then only we treat eczema. Even if they get secondary bacterial infection, it is the same. We treat infection first. So infection should settle completely before you apply steroids. Then this problem you know. Then this child, again an eczematous rash, but the problem is nappy rash, that is irritant contact dermatitis. So you have to advise them to avoid. So we have to treat the, advise them to avoid, advise them to wear Pampers during the night, and sometimes we give a barrier cream to avoid contact with urine. So there are so many barrier creams in the market, Happy Nap, nappy creams, or various things are there. So those are barrier creams. Those are not steroids most of the time. Those are barriers. So this atopic child, you know, in older children, the mainly flexures are involved. So it is not cured. Mother is not happy. doctor බෙහෙත් කළා හරියන්නේ නැහැ සනීප වෙන්නේ නැහැ මේ ළමයාට මේක නිතර එනවා. They are keep changing their dermatologist also. So we have to educate. It's good for us when they change dermatologist because we all get about 10 dermatologists get same person, same child. But the problem here is it takes 10 to 12 years to resolve. So we have to educate them. But they have to keep on, you have to keep on treating them because we have to symptomatically relieve their problem. Otherwise, their growth and the education and their eating habits, they all affected. So we have to control their disease, control their problem 90%, but it is only a control. We can't cure. 90% control can be done, but not cure. හොඳ වෙනවා නෙමෙයි අපි ඒක control කරලා දෙනවා විතරයි. ඒක we have to educate the parents. Right. So in summary, eczema or dermatitis is very common. Whatever the cause, the treatment is same. Antipruritics, you decide whether it is sedative, non-sedative, or both. Topical steroids. So depend on the strength, depend on the site and the age, you decide. If it is acute, you use Condis. If it is chronic, no need. And if there's infection, you give antibiotics, about maximum 3 to 5 days. So identify the specific cause, remove or treat the cause, avoid predisposing factors, aggravating factors, lot of emollients and moisturizers. So dermatology is visual diagnosis. So I have written with other colleagues several books. So they are in SLMA and PGIM library. So now this clinical dermatology in general practice, those books are over and no more in the market. And actually I have prepared a soft copy of a new book, but I don't have money to print because the printing is very expensive now. So it will take time to print another book, right, to the local market. But these are in international market, so very expensive. So anyway, these books are in libraries, so you can go and see. There are enough copies in PGIM and SLMA. There's a medical library. There are enough copies given. And even to the medical faculties, I have given copies, right? So it's a time for questions.
Madam, there are a lot of questions. We'll try to answer as much as possible. The first question is, what are the emollient types that we can use?
Emollient types, I think I explained it, depend on the dryness, you decide whether to use a cream, wait, and show, yes. So emollients depend on the dryness, you decide whether to give a cream or an ointment, right? So creams, aqueous creams are more watery, ointments oily, Vaseline is very oily, right? So depend on the, you have to read the cream and see whether it's like when you take a tube, you read it and see whether it's a cream or ointment, or it is whether it is Vaseline based. So depend on the dryness, you decide. Right. Next question.
If an infant has a rash only on the cheeks, would the infant definitely develop eczema on other areas of skin, or is there a probability of cure with infancy?
Yes, that depends on how you manage. Like I told you, we have to educate the parents. Then we give a mild topical steroid with antihistamine and lot of moisturizers. So the problem here is the parents want instant cure. So they don't want to hassle with topical moisturizers. Then they want instant cure. They like a doctor who prescribe oral steroids, which I don't do. So that's what happens. So the mild steroids and lot of moisturizers. It will stop at that time, at that area. But it will keep on going. Kyo කියන එක මම ඉස්සෙල්ලත් ඔයගලන්ට කිව්වා atopic dermatitis වල it's very difficult to tell මම මේක හොඳ කරනවා කියන වචනේ we can't use. We are controlling. But with time it will settle. It completely settles.
Madam, Madam, how frequently you have to apply emollient, and what about the soap using for bath in children with atopic dermatitis?
Atopic dermatitis, we advise them to use aqueous cream as a soap, right? But there are various things. There are some soap substitute where you can put some liquids onto the water. There are various things in the market, but the mainly thing what you have to read is whether they are moisturizers. So usually we use aqueous cream as soap. So they have to use this if you diagnose atopic dermatitis. Usually these children have very dry skin. So they have to continue moisturizers and this aqueous cream as soap for a long time, up to about 10 years.
Madam, if there's a secondary bacterial infection, do you give steroids straight away or do you let it settle first with antibiotics?
Any infection. So there are two infections they can get, either bacterial infection or viral infection they can get. And the atopic children, atopic children, they can get either viral infection or bacterial infection. So if you suspect infection, first treat infection. Don't give steroids. Don't give steroids to other leg even, because they mistakenly apply steroids onto this infected area. So treat infection first, get them down and see whether it has settled completely. Then only you prescribe steroids. Otherwise, you make this infection worse. Right. Next question.
Is there any relationship between vitamin B12 deficiency and eczema?
B12 deficiency, I don't know. I don't know, because unless there's a very recent research and publications, I have no idea. No. As far as I know, no. Zinc deficiency, yes.
If the eyelid eczema is not responding to hydrocortisone, what is the next option?
If what eczema?
Eyelid eczema.
Eyelid eczema, no. It's only hydrocortisone you prescribed, even in adult. Even in adult, you prescribe only hydrocortisone around the eye. Even around the eye, they should not apply for months because they can get glaucoma, right? So you apply steroids for a maximum about 1 week, then lot of moisturizers. They can get glaucoma, right?
What is the place for concomitant use of urea local applications in eczemas?
Yeah, you can apply urea, but because urea we give for dry skins. But there are different strengths. So for children, you have to give a mild one, 5% or 2% urea. Then for adults, 10%. But it's just for dry skin. But that also I don't prescribe for a long time because absorbing urea also can cause problems. I don't know what they can cause, but I think it's unnecessary to give a long time.
Madam, when do we consider initiating systemic steroid therapy?
Systemic therapy in acute eczemas only, right? Now see this one. Now this one has acute eczema plus swelling of both feet, right? So you have to give antibiotic because swelling is mostly due to infection. So you have to give antibiotic plus you can give a short course of steroids, maximum 5 days. Usually I give 3 days, right? So these acute eczemas, you can give short course of steroids. Even this one, this one, this is acute eczema. So you can give about 3 days and steroids, not long time. But these chronic eczemas, no use of giving steroids. It's not an acute problem. Right.
Madam, how to differentiate pityriasis versicolor from photodermatitis?
Psoriasis, versicolor, and photodermatitis, right. So we'll go to photodermatitis. We have this one. So this one is versicolor. Versicolor never become eczematous. The other one is versicolor has satellite lesions, but here also you can see some satellite-like lesions, right? But the other thing is versicolor, that is aluham, is a fungus and it grows, there's a fungal hyphae grows above the skin surface. So if you look from sides, you can see, you can see some hyphae coming out from the skin. You can see scaliness which has raised from the skin. You can see that. But that you have to do with a lot of experience, actually. Not a lot, but some experience.
Madam, we have one final question. What is follicular eczema, how to treat, and how to differentiate from heat rash?
Follicular eczema is localized. I don't have a picture here. It is a very localized lesion. Heat rash is like they have this heat rash all over the trunk and flexures mainly, neck and the flexures, they start heat rash. And heat rash is erythematous and both can be itchy. But heat rash, main complaint is pricking sensation. Heat rash, okay, not itching, pricking sensation. And it is widespread. Follicular eczema is very localized. But those pictures are there in my books. If people are interested, you can go and see them. Right?
That's all for the questions, madam. So I want to thank you, Dr. Ranthilaka R. Ranawaka, for your time and expertise today. This lecture was very insightful and thought-provoking and a valuable learning experience. I deeply appreciate your effort and dedication for this lecture. Thank you very much, madam.
You are welcome.
There's a link in the chat box. You can find it, which is the post-assessment form. You can fill it and give your feedback regarding this lecture. You can receive your e-certificate for participation once you submit the questionnaire with the link in the chat box. We thank you all for your participation and we hope you join with us next week on Sunday for yet another session of this webinar series. Thank you very much.